like to introduce our next speaker, Dr. Ganesh Raghu, who runs the Center for Interstitial Lung Disease in Seattle at the University of Washington, a world leader in pulmonary fibrosis, leading many clinical trials and innovating for now probably about 2 decades, I guess, Ganesh, or more. So welcome, Ganesh. We're really excited to hear you talk about the role of gastroesophageal reflux disease and fibrotic lung disease.
Thank you very much, David, and good morning, ladies and gentlemen. It is really my honor, and I'm flattered to be in front of you today to discuss the topic of gastroesophageal reflux and idiopathic pulmonary fibrosis. So that's the topic that I have been given, and I thank very much the organizers for asking me to do this. My disclosures are there. Yes, I have been a privileged consultant for designing many clinical trials. I do have research grant at the NIH. And above all, I'm an advocate for research and for patients with interstitial lung disease. I'm their primary advocate. I would like to thank you all again for coming this morning, and I'd like to thank the Fibrosis Foundation to have organized this, and also specifically the organizing committee who was willing to change this session because I had a little conflict and I needed to not be there this afternoon. I'd like to thank patients, caregivers, and families, and clinical staff of the Center for ILD who works with me, and sponsors and donor agencies who fund us for research. And above all, I'd like to thank my parents and my biological family and all others. But I'll tell you, I'd like to thank these people more than anybody else, my critiques, my peers, my colleagues, who keep me on my toes and make sure that I do things right. Especially, I'd like to thank these 3 wise men. This particular man, yesterday, Paul Noble, who's a good friend of mine, and said, Ganesh, you're still talking on the reflux? No, come on. It's just out. There's no way that reflux works. So anyway, thank you, and thank you. All right, so what I'm going to do is really talk about some microaspiration implications for diagnosis and treatment, and implications for prevention of injury and preventive measures for IPF. Well, we all know that the UIP pattern is characterized by the subepithelial fibrotic foci. And we all know that the recurrent microscopic lung injury must occur in the genetic predisposed person, and I'd like to think that injury is the microaspiration. The pathogenesis and course of UIP and IPF, of course, we heard elegantly this morning about the genetic factors. So in a genetically predisposed person, then we have multiple microscopic injury, which occurs over time, and whether that injury is instilled, and I'd like to say instilled by microaspiration, or inhaled, or systemic, arriving by circulation. This occurs over time, and the fibroblast proliferates and proliferates. And in turn, the fibroblast proliferation deposits collagens, extracellular matrix, and scarred lung, and disease progresses. And meanwhile, there is always a recurrent microscopic injury, and the disease unfortunately progresses to reach fatality. This is the sad scenario of the idiopathic pulmonary fibrosis from a conceptual manner. So if that recurrent injury to the pulmonary parenchyma is an essential component, is that injurious agent could be the acid gastroesophageal reflux. Now here's the hypothesis. So in a genetically predisposed person, the microaspiration going all the way up to the larynx, clearing the throat that many people do have, and settles in the lung and perhaps causes injury to the epithelium, and then promotes the cascades of events of pulmonary fibrosis. So shown here is another cartoon in terms of the aberrant wound healing model that Moise Salmon and Annie Pardo told us a long time ago. But the problem is, the situation is, it occurs, the recurrent injury occurs. The microaspiration doesn't occur every day. It depends upon what we do, what we eat, how we sleep, all of the factors that predisposes people to have microaspiration. Well, the esophagogastric junction is where we are talking about. This is the gastroesophageal junction where the lower esophageal sphincter is there. And the reflux of the gastric contents to the lower esophagus is a normal postprandial inflammation. We all are aware of reflux. But the damage depends on the duration, the extent, the intensity, the acidity of the reflux that gets into the lung by microaspiration. It depends whether the esophageal is working in terms of peristalsis. It depends whether there is a salivary neutralization or not. The lower esophageal sphincter relaxation is an important aspect, and it could increase or relax with increased intra-abdominal pressure, such as truncal obesity. Some people have atonic LAS, or lower esophageal spontaneous free reflux, and hiatal hernia is there, and other factors. Caffeinated beverages, carbonated beverages, any alcohol beverages, fatty food, spicy food, anything that we like we did last night. Drugs that relax us, smoking. These are unsleeping habits. So we eat late, glass of wine or two, then go home and sleep. Then you have sleep apnea, you have increase in abdominal pressure, you microaspirate. It's unclear if this is really an aging phenomenon. So the observation that comes forward is many: human, experimental, and clinical observation and implications. The clinical observations are actually quite extensive. It goes back to the 1960s and 70s. And a long time ago, Bartlett said triple aspiration pneumonias. We're not talking about bacterial aspiration pneumonias, although I'm intrigued with the lung microbiome, with the aspiration oral flora getting into the lung and cause acute exacerbation may actually be a conceptual hypothesis. So there's tons of evidence that microaspiration may be playing a role in idiopathic pulmonary fibrosis. A case-controlled study shown here with a univariate analysis shown that the diagnosis of gastroesophageal reflux and antacid, an ulcer history, has an increased risk factor to have idiopathic pulmonary fibrosis. And if you take in terms of the medications, insulin and ulcer drugs, people taking antacids or ulcer drugs have an increased risk for idiopathic pulmonary fibrosis. Long time ago, I came up with this idea in terms of maybe they do have abnormal acid gastroesophageal reflux, and a paper that we published in 1998 actually shows that 16 of the 17 consecutive patients were very high abnormal acid gastroesophageal reflux, and it occurred even when they're upright, and it occurred all the way up to their laryngeal areas. And only 25% of the patients had symptoms. So vast majority of them did not have any symptoms of gastroesophageal reflux. If you ask these symptoms, no, I don't have any acid gastroesophageal reflux. We then did another study using a case control of patients with asthma. These are intractable asthma patients who were having potential of gastroesophageal reflux. And the prevalence of the abnormal acid gastroesophageal reflux were 87% and 76% even in the proximal LES, or proximal esophageal sphincter. So we then monitored the esophageal acid exposure, people who were taking antacids as well. And shown here is the next slide, is that people who were on anti-reflux therapy, which is proton pump inhibitor, also had still abnormal acid gastroesophageal reflux. So these people were taking the PPIs during the 24-hour pH monitoring. So the conventionally used PPIs not necessarily suppresses acid in all patients. So in patients with well-defined IPF, it is clear that they have abnormal acid reflux, and only minority of them have symptoms. So conclusions from both of these prospective studies was clear to me that there is abnormal acid gastroesophageal reflux that occurs both supine and in upright position when patients are awake. Hiatal hernia is an increased risk factor, and Imre North showed this very elegantly, that hiatal hernia is also an increased risk factor or have abnormal acid gastroesophageal reflux. Progression of IPF lessens from asymmetric disease. Every now and then we come across with patients with unilateral disease, to the point that when I see those patients, if a patient is with his spouse, I said, I bet you he sleeps on his right side down. How did you know? Well, the right side down here is the fibrosis. The theory is that the dependent lung, when you lie down, and if you are having microaspiration, it gets down into that lung. So asymmetry of pulmonary fibrosis in IPF was ascertained, and this correlated with abnormal gastroesophageal reflux symptoms when asked for. So the step theory of the IPF progression, we all know that there is a stepwise decline, and there is an acute exacerbation that occurs. And I submit to you that maybe the acute exacerbation is precipitated by microaspiration. And indeed, a bronchoalveolar lavage done during the episodes of acute exacerbation, documented pepsin, digestive enzymes, forget about the acid. So digestive enzymes settling down in the lung can actually distort the pulmonary parenchyma with injuries. I have an interesting case that came to me not too long ago. There is a series of CT scans that you can see in the top minus 27 months, that's IPF. And then day 0, he came to see me for an evaluation of rapid decline. In front of me, on that particular day, I said, well, you need to be evaluated for lung transplantation. So I asked him to have an urgent right and left heart catheterization. So that night he went home, and the next day he had a right and left heart catheterization, and in the afternoon I was asked to come to see him because his oxygen saturation desaturated acutely, abruptly. And he was manifesting acute exacerbation right in front of our eyes. And he passed away, and his autopsy showed diffuse alveolar damage, organizing pneumonia, consistent with aspiration pneumonias, as well as gastric cells in the lung with IPF lungers. So people have criticized, how can acid really get into the lower portions of the lung? Here we have an evidence in this particular case that by immunohistochemistry, gastric lining cells were in the areas of the lung of acute exacerbations. So the prevalence of abnormal acid reflux is clearly there. And Melaine Hahn wrote this nice article, or at least a letter to the ERJ, saying that the odds of having IPF in those with abnormal acid gastric reflux is very high. Attributable risk percent, she called it, is 68% of patients. And she went on to say that population attributable risk is 49.8% in the population studies, almost half of the IPF cases, and only 47%, of course, had symptoms. And she said all patients with IPF should be treated with proton pump inhibitor. So the conclusion to me, at least from all of this, the association between abnormal gastroesophageal reflux and IPF is clear. The clinical observation for treatment. So then I started to think about, well, maybe we should treat patients with abnormal acid gastroesophageal reflux. So I did it. The hypothesis was if you control the acid reflux, you're going to stabilize the disease. So we took a few case series, patients newly diagnosed who declined to participate in clinical trial, who didn't want to be on prednisone azathioprine at the time, and didn't want to be receiving any new agents. So I took 4 cases, and shown here is a 4-case summary followed over a period of 3 to 5 years' time. And a summary of that is shown here. These people were declining, and upon treating with proton pump inhibitor treatment, and some of them with reflux surgery or anti-reflux surgery, they stabilized. So this was an important observation, at least for me, that this control of the acid gastroesophageal reflux, and sometimes with anti-reflux surgery, that they stabilized over time. So then one of these patients said, well, I think my son is having reflux problems, you should see him. So there is a 73-year-old patient of mine with idiopathic pulmonary fibrosis who was getting better with the antacid, and his son, the 47-year-old person. He has no fibrosis by the CT scan. The interstitial lung disease is slightly prominent by radiology, and his diffusing capacity is 70%. He doesn't have idiopathic pulmonary fibrosis, but then why does he have diffusion capacity measurement which is decreased? He has abnormal acid gastroesophageal reflux, so therefore I started to treat him because of the abnormal acid gastroesophageal reflux and conservative measures, and followed him over 2-3 years' time, and his diffusing capacity is normalized. Now perhaps if this guy did not control his reflux, maybe he would manifest idiopathic pulmonary fibrosis. Those are all the conceptual hypotheses that is going on in our minds. So the guidelines recommendation in 2011, taking these into account, said, well, treatment of asymptomatic reflux is a weak yes. That means what it meant is that the majority of patients would want the treatment, but a minority may not. We then had a study with the NIH IPF NET studies where we actually designed the case report forms prospectively to capture how many patients were taking PPIs and how many patients had gastroesophageal reflux. And if you look at this data, that it shows that the blue columns, that the rate of the forced vital capacity decline in the placebo arm patients who were receiving the PPIs, they were slowed down compared to those who did not. And also shown in the insert here is that there is no acute exacerbation in these patients. Patients with antacid treatment, therefore, were actually slowing down their force vital capacity, and they did not have any acute exacerbations. This is not a randomized controlled trial. This is, therefore, it's a placebo pool data, if you will, and so therefore this data has not compared to the surgical therapy. But anyway, there are some signals in this, to the point that the new guidelines in 2015 committee that reviewed all of this gave the following recommendations. You will see that the 4 conditional recommendation, in addition to the nintedanib and pirfenidone, there is this antacids. This has been criticized appropriately by our peers and colleagues. How can this committee come up with a conditional recommendation for antacids compared to a robust clinical trials done with nintedanib and pirfenidone? To the point that, well, there is also some other perspectives that we think that the proton pump inhibitor treatment have actually could be an anti-fibrotic drug in vitro. So the antacid therapy has been poo-pooed quite a bit subsequent to that conditional recommendations. Here's an article that I'd like to share with you by Michael Kruder. The conclusion of this is antacid therapy in disease outcomes in a pooled analysis is actually harmful, potentially, to the point that Steve Nathan wrote in editorial. He said, look, if you really need it, there's already data. If further data is required, then interested parties would need to look no further than another abstract that it is harmful. The point of this particular paper was that is a pooled analysis and a subgroup analysis, and I wrote an editorial correspondence to the Lancet that this particular paper should be interpreted with great cautions. The reason is this. The major concerns of that paper that hit the Lancet Respiratory Medicine is it's a pooled patient population. The design was never designed to address the risk factors for the infections. They never even defined what infection was. It was based on whatever the clinical site investigators said, well, infected. The respiratory infection proposed to be associated were in a subgroup of patients who were very ill, with FVC down to 70%. Maybe they were aspirating. Maybe that's why they were ill. So the other major concern was that less than 70% predicted at baseline was defined post-hoc. So it already is an exploratory, and then they're dissecting it out as a post-hoc analysis. These are all important concerns that you should take into consideration before extrapolating. So the other concerns were that these particular patients were not even followed closely enough, whether they were following conservative measures, whether they were taking the PPIs every day or not. So when I wrote this correspondence, the authors replied back. So what did it say? We thank Ganesh Raghu for his kind interest in this article. Currently, the role of antacid treatment as a therapy is unclear. So in conclusion, we completely agree. So that was the response. So how should we manage them? Should we manage them with fundoplication or antacid treatment? In a retrospective data, there is data to suggest that anti-reflux treatment as well as surgery improves survival. Here's the survival curve shown in terms of the history of fundoplication improves survival. This is a retrospective data. So the effect of laparoscopic fundoplication, we started to look into it in a retrospective manner. So we published this in a series of 27 patients with idiopathic pulmonary fibrosis undergoing laparoscopic surgery. So in the interest of time, so I'll tell you that this, if we know that in the IPF net trials, the rate of decline is about 200 cc. In these patients, in the laparoscopic anti-reflux surgery patients that we followed, before they went to the fundoplication, they were declining at a rate of about 300 cc. And after the surgery, that their decline was a little bit less. Now again, this is a retrospective data, so you need to pay a little bit caution in terms of attentions. Nevertheless, using a regression model, the estimated benefit of surgery in FVC % predicted was there. There was a trend in the post-patient's laparoscopic surgery. The survival also appears to be a little bit benefited in these patients. Now, considering that the median survival of patients with idiopathic pulmonary fibrosis is about 3 years, and these patients were already 2 years before, and after the laparoscopy, they seem to be surviving a little bit longer than not. Nevertheless, these are all signals that has provided a little bit of a strategy for a novel treatment for preventing further insults. So only prospective studies can So new directions are needed with current concepts in the pathogenesis of IPF with genetic factors, risk factors, as well as there is no studies currently to design to avoid and potential risk factors. So the new direction, what I propose, therefore, is preventive measures is better than cure. The intrinsic risk factor to initiate or manifest the lung injury with microaspiration of gastric acid should be taken into consideration, and whether the increased survival that we have seen, is it a myth or a fact? Only prospective randomized clinical trial will determine that. Indeed, there is a prospective study going on, which is almost complete. It's called RAP, idiopathic pulmonary fibrosis. Much to the Rex Edwards, who is the vice president of PFF, he came up with this in his previous life before PFF Foundation, called RAP, idiopathic pulmonary fibrosis, weighing risks and benefits of laparoscopic anti-reflux surgery. This is an NIH-sponsored trial. Privileged to be, Hal Koller and I are the co-principal investigators of this NIH phase 2 clinical trials. The primary hypothesis is that laparoscopic anti-reflux surgery will slow the progression of IPF. Secondary hypothesis is laparoscopic anti-reflux surgery will reduce the frequency of acid reflux, will be safe and well tolerated, improve symptoms and quality of life, and reduce the incidence of acute exacerbations, hospitalizations, and disease progression and death. The specific aims of this is, of course, looking at the forced vital capacity at 48 weeks to correlate the reduction of the reflux events with the correction of the abnormal reflux, determine the safety of the laparoscopic anti-reflux surgery, explore the impact of the laparoscopic anti-reflux surgery with secondary endpoints, and more importantly, equally importantly, is Paul Walter has taken an ancillary study looking for molecular aspects of epithelial injury in these patients between pre and post laparoscopic anti-reflux surgery. Here's the design, a randomized controlled trial. People should have abnormal acid gastroesophageal reflux, and they're randomized to get laparoscopic surgery versus medications. There are 5 sites. We started out with 5 sites. We needed to add 1 site because the recruitment was a problem. It was not an easy recruitment for this particular study. We only needed 58 patients, but it took us quite some time. So there's myself and Hal Collard as the co-principal investigators. We have the NIH. We have Kevin Anstrom as the DCC, and University of Wisconsin, University of Michigan, and University of Chicago, and we added Salt Lake City. The recruitment has been difficult, as I said. Here's UCSF bringing 6 patients, Chicago bringing, or Wisconsin bringing 6, 8 patients from Michigan, and 4 from others, and 1 from Salt Lake City. So recruitment has been very difficult because of the abnormal acid reflux they all have to have. And we have been we've been fortunate to get 33, and we have been able to complete the enrollment. And the stage is that we have completed the study, data is being analyzed, we anticipate the results by ATS or earlier then. So if it was good enough for Aristotle, it should be good enough. Thank you very much.